Hello and welcome to the Leading Communities podcast, brought to you by Aspire for You CIC, Ideal Directions Marketing, and hosted by That's All Media CIC. This podcast has been put together to help community leaders learn from proven leaders from proven organisations. My name's Marianne Delaney and I'll be your host. In today's podcast, we will be focusing on health and behaviour, and we have health psychologist Alison Trout with us, as well as Kiran, Sodha, GP with an interest in understanding the root cause of disease and mental health. Welcome, everyone. All right, thanks for joining us. We also have Kit Shawande, who'll be joining us on behalf of Kate Walker. Do you want to let us know a bit more about Kate and her organisation?
Kate Walker runs Steps to Your Healthy Future. They're a charity actually, based in Birmingham, and they do a lot of delivery of interventions around diabetes, interventions that are trying to help people with behavioral change and just making healthy choices. So they've tried to run different things like campaigns. They're active in Handsworth at the moment, as we speak, and it's quite a small organisation that's got ambitions to do more. So their journey of leading communities is more from a health perspective. So that's where your expertise come in. Do you want to tell us maybe a couple of things about yourselves, your background, how you got into your particular area, and then we'll shoot into Katie's question.
Alison, do you want to go first?
So as you say, I'm a health psychologist, and my background is really mainly in public health. So I've worked in both provider services and worked as community lead for public health, and more recently as kind of leading on behavioural science. So I also work as a clinician, so with people with diabetes.
My name's Dr. Kiran Sodha. I'm a GP, and I don't know how to keep this story short. So I want to sort of tell you about how I got into what I do now. And a lot of that comes from some of the books I started reading after I qualified as a GP. And the reason for that was because I was finding, especially in mental health and with conditions such as anxiety and depression, I was finding I was putting people on tablets, but the tablets weren't curing them. They were just helping or managing or palliating. Also, even sometimes we're having to continuously increase these tablets without seeing clear benefits. And so I started on this reading journey. In fact, the books I was reading were business type books, leadership books, but also other type medical books, and looking into sort of alternative medicine. And I read a book, and that book changed everything that I feel that I learned from medical school. Essentially, I feel that medical school had given us this great physiology and understanding and biomedical understanding of the body. But then by the time we'd finished medical school, we were taught to treat everything with either drugs or surgery. That was essentially the way I found that we were taught. And there was a complete disconnect between the last 3 years of med school, which was all about pharmacology and the clinical side of it, and the first 2 years, which was all this physiology and beautiful biochemical stuff that we learned, but actually weren't applying it to what we were doing. And after that, I embarked on a journey and spent quite a lot of money on learning a whole new set of tools to try and treat patients. So I became a member of the British Society of Lifestyle Medicine. That was inaugurated around the same time. So I was one of the founding members of that. And I started doing a lot of training in functional medicine. And essentially all of these come down to the root cause. What is going on that's driving illness to the point, or developing illness in the first place? So rather than just attacking it from the front end, essentially trying to treat things straight away, also looking in the long term how we can prevent those diseases from developing, and essentially not just managing them, but trying to cure them or trying to end them.
Excellent. Okay. So leading from that, because that's actually a really good starting point. So Kate from Steps to Your Healthy Future, her first point is really around, there are lots of projects and voluntary organizations in the community that give help and advice. We find it difficult to encourage people to come and see if we can help them. How do we get communities to change behaviors and engage with us? So this question is really about, how do you start an engagement journey? So, there's a community service that offers something around diabetes. People probably a bit curious or something like that, but how do we actually start them engaging with us? What are your thoughts?
I'd say the most successful organisations that I've seen engaging with the community successfully are those that kind of start at the grassroots level. So they start with the community and bring the community with them. So they might start, and I can think of a good example of an organisation that I've worked with in the previous role, where they were a kind of horticultural project, and they went out into the community. It's a very deprived area of Birmingham. Went out into the community and just started to dig and started to dig up the ground that they were kind of going to do the work on. And then the community kind of came out and said, "What are you doing?" Then they said, "Well, we're just trying to kind of make a community garden here." So then the community came out and they started to help, and then they took ownership of it, and it has been really successful. And the organisation have recently run the MBE, I think about a few weeks ago. Incredibly successful, engaged with lots of people in the community, particularly people with learning disabilities, people with mental health problems, people in the criminal justice system. It's been very successful. So I'd say that would be one way to engage. Definitely important. But also, if you don't know, if you're not sure, then go and ask the community, who are your target groups? Who do you want to get feedback from? Go out to the places that you know your target community go to, ask the questions. If you're able to, look at, you can look at the literature. Are there other things going on, other areas that are similar that you can draw on from what made it successful, what made them successful? You can also do focus groups if you feel that if you have the resource to do that, they can be really insightful. Talking to other stakeholders that are involved in that community can also really help. So I'd say that's the way to find out a bit more about why the community might not be engaging with you, and the facilitators, which might mean that they do engage with you in future.
Okay, so with that facilitator journey, just maybe explain that a little bit more.
In terms of finding out the facilitators to what would make it more likely that they would engage.
Okay.
And I suppose the key things are finding out about what we talk about in behavioural science is the framework called the COMBI, which essentially stands for capability, opportunity and motivation. If those things aren't in place, then people won't do the behaviour. Okay, so often we provide people with, as councils or the NHS, we might provide people with the opportunity, particularly councils, or the capability to some extent, but we don't think about the motivation often, and that's really important. And we need to factor these things in, because if something is motivating a person not to do that activity, then what you need to create a motivation which is stronger than the motivation not to do that activity.
And what's the B and the I in COMBI?
B is the behaviour. So C it's C, capability,
opportunity,
motivation. If those things aren't in place, then people won't do it. And the other thing I think that's really important is another behavioural insights team brought out another framework called EAST, which is that you need to make sure that you make things easy for people. So it's an acronym: attractive, sociable and timely. Okay, so in terms of making things easy, take away any friction costs, as we call them. So for example, why might that person not be attending? Is it because they have to get 2 buses to get there? Is it because you're asking them to fill out a lengthy form beforehand? And to make it attractive to people. So what is it people in the community find attractive? So if you're looking at physical activity, what activities do they find attractive? It's not the same as we might find attractive. Everybody doesn't want to go for running, so it might be something completely different.
So true.
Yeah.
And the sociable? Sorry.
Sociable, yeah. So making it sociable. So and obviously the impact there as well is on mental health. If you're looking at physical activity, if you can make things sociable, then people find it more attractive. They're more likely to have benefits to their mental and physical health by doing it, and it kind of and timely. So things like starting a campaign at the start of the new year when people set New Year's resolutions. So for example, being more fit and healthy and stop smoking or going on a diet, or activities around the summer holidays when kids are going off on holiday. So you know that the likelihood is they're going to take those options up. So yeah.
Sorry, Kiran, you were saying?
Yeah, I was going to say that really resonates with me. And actually, you said two frameworks there, the COM-B and the EAST. Both the first time I'm hearing about them. But the COM-B, is that still used as much?
That is gold standard kind of a frame. Well, it's a model. So it's a model that sits, and there's a framework called the behaviour change wheel that sits around it. But COM is a really easy, simple way for you to think about, you just think, why isn't somebody doing something? Is it, and you just kind of straight away think, is it because, what can I do about it to increase their capability, their motivation, or their...
I was going to say that EAST actually appeals more to me than COM-B, because those words that it's using seem easier to sort of understand, and then try and understand why something isn't working. For example, easy and attractive. Why isn't something attractive? Whereas using the word capability for a lot of people might be a bit more abstract somehow.
I think how you might see the COM-B model is that the COM part of it is about diagnosing what the issue is, and then the EAST framework helps you then to address it. So how do we make it, if it it's just a kind of, they're both useful to consider whenever you're doing anything, really.
So they're actually slightly different contexts in which you use them.
Yeah, but you can use them together, but it's slightly different.
Is it more of a progress, really? So you'd start off with the COM-B to kind of figure out exactly what you want to do and how you want to solve an issue. And then the second part is the connecting to the individuals that you want to, basically help, really.
Yeah, so you work out and then you decide on strategies to address... I don't want to get into the complexities, because there is a framework that sits around the COM model, so I'm trying to keep it easy. But I think then you need to work out how you would then address, and there are ways to do that by using the behaviour change wheel, which is kind of beyond probably the scope of this conversation, but that does really help. But it's making you think really about what's going on in this situation, what haven't I considered, what might I, and when you're designing any new campaign or intervention, to think about, how do we use EAST? How do we make this easy for people? Just simple things like putting, if you've got a new activity, putting a map of where it is into the letter or to the leaflet or whatever it is, really helps, because people can see it, and it has a really big impact on the likelihood of people attending. Just something simple like that.
Dr. Kiran, behaviour, like how do we...
Well, I'd written down a list, and actually there's just so many similarities between what Alison said as well. So I've written, my list was trust. People need to trust that the information or the behaviour change or whatever it is that we're trying to engage with the community, they need to trust it. We need to make it easy. So that's where it goes with easy, with EAST. Because if we don't make it easy, then the alternative is just so much easier, which is the status quo or whatever they're doing at the moment. And listening to their wants, and for them to understand what we're trying to achieve for them as well. I think that's really important. And again, that's about getting the right stakeholders around the table. So you're going to find that you've got decision makers who've got the power with the purse strings and where money flows and what kind of happens. But then at the same time, you've got the people with the knowledge, or the people who would know perhaps how best that could be used on the ground. And so bringing those two together and making sure they're having the conversations, I think is really important. I think there's actually a graph, I can't remember what it's called. On one end, there's your people who know or the people who it affects, and then you've got your decision makers, and it's about bringing them two together, essentially.
So in some ways, the answer's not necessarily exciting, but it's very practical, which is immerse yourself in that community that you're trying to do things with, take the time to get to know them, actually give a damn about them, and then just, things then evolve gradually. Now, this is obviously a wider question, but in your maybe experience or as a guess, how long does it take to spend time building trust? How long does it take to start to assess capabilities, opportunities? How long does listening take? It's a very hard question, but it's deliberately hard, because the average social entrepreneur, the average organization, maybe is living month to month, and they need to get impact, they need to get results. So how should they be thinking about the time to dedicate to doing the right thing?
That's a really difficult question.
And it's an open thought, discussion,
I think, in my experience, it can take a while because it depends on the context. If it's the starting position is that the community don't trust that organisation that you're working for already, then it can be a more difficult job. Or if there's certain characteristics they associate that organisation with. Some organisations are more trusted than others. So if they trust an organisation to start with, it's much easier. So some of the work has to be made about building bridges to start with. But if that's not an issue, I think I'd say the most valuable thing is probably going out and speaking, if you've got limited time, to the key people and asking and getting a really in-depth insight, spending proper time with them, understanding the context that they're working in or living in, so that you get a full insight into that, because that's gold really, because I think that's the key thing. If you can run focus groups, fantastic, but they do take more resource.
I haven't got experience on a large scale with communities, but on a one-on-one with individuals in general practice, it can vary hugely. And I find that the further your appearances or your cultural background is to that person, as a roughly that increases the time that it takes to develop that trust. And I think that's just human nature. So if someone comes in about my age, dressed similarly to me, I think they're more likely to trust me, and they're more likely to open up initially, compared to someone else who's of a different age to me and maybe who's female, may be less likely to open up. But that rapport always builds. It always I don't think you can put time on it, but you can build it.
Doing the right thing takes time is the ultimate answer. And I suppose if people are in it for the long haul, then it just needs to be done. Yeah, that's great. Okay, and then the next question from Kate is really centered around looking at, doing the right things for one's own health on a consistent basis. And she asks, how do you think we can support people to make long-term behavior changes?
I think, Alison, you're probably more of the expert on this, but I've got my own opinion on it too. I mean,
do you want to start with yours? Yeah.
Where I come from on this is a little bit from understanding my experience with patients, reading those books that I've been reading, and also I've been studying an MBA at Warwick, and one of the modules that we do is around behaviour in the workplace, and a lot of this that we're talking about today is very similar to that. So for me, it's about extrinsic or intrinsic motivation. So meaning, what are the external factors that we motivate people, or what is it internally that motivates people? And if we hit intrinsic motivation, so those that make people compelled to do things without even thinking about it, then I think that's what will get people to consistently make change. And so to do that, I think the biggest thing is it just needs to be easy, and people need to not realize why they're doing those changes. So, for example, one of the books that I read, which was hugely powerful, is a book by Daniel Bretner, which is called The Blue Zones. And he's done a second book, which is how you can change your life based on these blue zones. And these blue zones are essentially where people are living the longest and the healthiest. And they're not correlated at all to those areas who are more affluent or have the best access to healthcare. And so these people, what they're doing, they're not doing things for 3 months in a year. They're not doing things just in certain periods. They're doing things consistently, day in, day out. And it's those little things, such as not doing a marathon once a year, but actually walking every day. Those are the things that are making the biggest difference. But the difference between that is it's easy to walk every day if you have to go to work and it's 3 miles away and you don't have access to a car. Then you have to do that exercise. But if you have access to a car, then you don't need to do that exercise. And so you will take the easiest route possible. So if that person got hold of a bicycle, probably take the bicycle. But if you've got a car, you'll take the car because it's even easier. And I think it's about that intrinsic motivation.
So that's a really good kind of point that you said, that actually, make it easier in order for it to be accessible. What would your thoughts?
Okay, so and I completely agree with what you said there, and particularly around the intrinsic motivation and making it easy. I think the thing is, if a behaviour is to become, so say for example, we were looking at getting somebody to become more physically active, a new behaviour like that takes a while to become a habit. So the average is around 3 months before something becomes a habit, although it varies, okay, depending on what the behaviour is. So I think if you can get people to that point, then that's the point at which they can like loose your hand, if you like, and then you can kind of say with some degree of certainty that behaviour might be maintained. So that's the key thing. So sometimes getting people started is the easy part. It's kind of getting them to maintain that behaviour. And I think the other thing is people do know generally what's healthy and what isn't, and what they should be eating and what they shouldn't be eating. But the problem is that if they see others in their environment who are not doing the healthy behaviour, or the environment isn't conducive with that healthy behaviour, so their work environment or their home environment or wherever they're living isn't conducive with that, so they haven't got access to certain things, then they're less likely to do it. And I think the thing is as well that the more we know about behavioural science, what we're starting to understand is that it's easier to change the environment than it is to change people's minds, because we've spent in public health for years, we've spent a lot of time looking at how we can get people to read leaflets and weigh up the pros and the cons. And actually it's not that effective, and it's got the potential to increase health inequalities, because the people who do that tend not to be our target groups many times. So I think there's more and more evidence that changing the environment is the best way to do that, whether that's changing the environment in a small way through nudges so when you go and buy food in a shop, you bring the fruit and the vegetables close to the front and push the healthy and unhealthy stuff to the back, or whether that's changing, so smaller. One of the most effective things for losing weight is portion control plates, so things like that, and also, or kind of the wider environment, the infrastructure, building cycle lanes, kind of having bike stands so people can see that they're a normal part of the environment, can all make a big change. And I think there's some really good examples of successful initiatives. Can I mention the name of one? There's an initiative called Beat the Street. I don't know if you've heard of it, but that is it's a GP that started that up actually, and it's basically it gets people in communities to become activated in small groups, in schools, in community groups, in families, to kind of have a healthy competition between each other. So the idea is that they have these kind of like cards, and they swipe them on these beat boxes that are on lampposts whenever they're out and about walking. And basically between lampposts they can earn points, so the more you walk the more you earn, and then they give prizes to the highest winning groups at the end of it. And they've just had a lot of public health organisations are commissioning them now, and they've just had their 1 millionth person this last week who've actually gone through this process, signed up to it.
Is that in Warwickshire, Staffordshire?
It's all over the country, but the different places are doing this. I know Leicester are doing it, other places, many of the London boroughs have commissioned it. And I suppose it's helpful because they're there for quite a few weeks, so they kind of get people to establish the habits of becoming more active. It's been very successful where it's been.
Any other good examples?
Any other good examples? I suppose that's the one that springs to mind more than anything else. I think the example I give about the horticultural project, which is the kind of Grow Organic, which I was mentioned earlier. They're a local organisation.
Do you want to tell us a bit more about
They're
it?
a community enterprise.
Yep.
They were initially based in the North Solihull area, but they also work across Birmingham now in different projects, and they managed to get like key target groups who we would refer to as target groups within public health to come in and become more physically active with gardening projects and horticultural projects, because gardening counts too. And that was maintained as well, so that kind of people then just took over the garden and it became their garden. It's part of the ownership, and they didn't need to be encouraged anymore to do that. I think the other thing to say as well is, while I'm on it all, is the important, I think what we often forget is around targeting belief systems, because we often just say, we need to do this and we'll put things in place, but we don't really think about what people's beliefs are. And, you know, and a good example, I think, is when you're helping people to, say, quit smoking. Often they'll have the belief that, for example, if it was that bad, it wouldn't be legal, or that's one of the hardest ones to go. Or another one would be, it stops me getting stressed.
Yeah.
So myth busting.
Helps
So
me lose
tackling
weight,
people's well, just tackling some of the beliefs can be really helpful in getting people to a point where they change their behaviour. But we often don't think that one through as well, I think, and it's a point of focus.
That's really interesting. I think the point about beliefs is definitely, I think, one that we don't talk about enough, because that's part of that motivation and the operating system. Because if we've rationalized a behavior and it's justified, then that works. There was also, interestingly, with Grow Organic, it just hit me. They were actually, or one of their team was getting bid writing training with us, like literally 2 weeks at Ken's ago. So as you were describing that, so that's quite interesting. But a lot of what you actually said made me start to think about, you know, the wider ramifications, which is, if we want actually long-term change, we need to work with the environment that within which, and I think that lends itself to a lot of conversations around youth violence, domestic abuse, domestic violence. So some of the actual, you know, huge issues in society actually sounds like it's not just about those people there. It's all about, it sounds more like all of us here, and what are we gonna do about this wider ecosystem. So that's a really strong way for me to start thinking, and it makes me then wonder about the projects that we plan. How often do we actually maybe build in environmental change and looking at, well, okay, yes, you've done this intervention, but then what's gonna evolve, what's gonna change, and how do we get maybe better facilities? How do we make it easty? That's got to be like on the office wall now.
East.
Make it east.
Make it east. All points east. Look, I've got a personal example with cycling. So if we just think about the environment, for me, my dad's an avid cycler. He's sort of more of a hobbying cyclist rather than a sort of long distance cyclist. And I've grown up with that. And when I was in London, I had a car as well, because we needed to for some of the work that we're doing in general practice. And on weekends, I found a free parking space near Oxford Street, and I used to drive down to Oxford Street. When the legislation changes happened with ULEZ recently, so because my car's a diesel car, I can't now take it to Oxford Street down that area any day of the week. It meant that I was cycling instead. And also because the year before they put that in, they doubled the cost of parking, paying for parking as well. It meant that I was less likely to go as well. So actually I cycled more. And so, like you said, it took 3 months? It takes 3 months to get that into your system. So after 3 months, it became a year. And then I moved to Birmingham. And in Birmingham, they don't have the cycle infrastructure that they have in London. And there's less incentives. But actually, I'd already had that ingrained in me. And it was costly to park at places in Birmingham. And I got a parking fine. And after that, I was like, right, I'm cycling. And it only took me 10 minutes to cycle from Brindley Place here. So it's faster than a car. If I was trying to do that in the car and then park and everything, it would have taken ages. And because it's become easier for me, I can take the train, Chiltern Railways train with my bike, but I can't take the Virgin with it because it's too much of a nightmare. So that means that I can take my bike now on the train to London and between London and Birmingham. So again, if you make the environment easier, it means that you can continue doing what you can do, but also conversely, make the other things less attractive. So make it more expensive to park, make it more expensive to drive into London. And it means that you end up changing your behaviours. And actually at the moment, because of my lifestyle at the moment, moving between Birmingham and London, I do less exercise, but most of my exercise comes through on the bike now as a result. So that's what's helping me stay healthy, just because it's more difficult to park and easier to cycle. And also being in that environment of, I got a flat tyre last week. Instead of dealing with it myself, I took it home and my dad sorted it out for me.
I love that. And then Kate then points out saying, at a national level, what do you think the key messages need to be so people can aspire to succeed in small steps? So I think this is now linking a little towards policy. My interpretation would probably be, how can policy help support incremental change? But her question is, at a national level, what do you think the key messages need to be so people can aspire to succeed in small steps?
So I think that many people see, if you are talking about physical activity, they don't tend to see it as they tend to see it as running, or but that's not, we're not trying to get people to run marathons, but that's often what people see it. They see it as some unpleasant activity, that it's going to be a chore, discomfort. So I think it's one of the messages should be, or I think it probably already is, it's about small changes to people's lives. And it's about making things enjoyable for people. That's what it should be, and fun. So fun activities like the one we just talked about when we talked about the Beat the Street. That's a kind of fun activity for people. And so I think that. So can I talk about another example? Anybody you've heard of Man versus Fat at all?
The TV show or something like
No,
that?
it's Man versus Food.
I think that's the opposite, isn't it?
That's where it comes from, though.
This is why we need the Man versus Fat. That's what we need in our lives.
He came because of the prequel.
So the idea was that we commissioned Man versus Fat a few years ago, and it was really successful for us. It's basically what they do is, and the guy who is the chief executive, Andrew Shanahan, he trialled it with us to see if it worked, and it was a football team, and it's not the first football team that's been trialled, but I think it was the way he went about doing it. It was very cleverly done in terms of marketing. His background was kind of marketing and journalism. And so he set up a men's football group, and it was kind of the beauty of it was that it was for guys who were overweight, so for men who would be what we call BMI over 30, body mass index over 30, and they could join the group, and it was all men together in it for the same reasons, because often it's people don't feel quite self-conscious, so all the men were in the same boat essentially, and so they got together and ran these courses that went for 14 weeks, so really, within the kind of beyond the time frame of 3 months of forming a new habit essentially. And really big success with this, and people who attended also started to make new friends, and their mental health improved. There was the right knock-on effects, and it didn't feel like it was a kind of chore at all. It felt like it was like a really enjoyable activity for people to do. So I think trying to make it, making it achievable for people, make it the small steps, making sure that it's, something that people are going to enjoy and find fun. So I think that's the key. And I think trying to get people as well to start thinking through what is it you want to do. If you want to make a change, don't just say, I want to be more active. You need to actually say things like, what is it you're going to do? Make a commitment to yourself. So be specific. Rather than saying I'm going to be active, you can instead say, I am going to walk to work 3 times this week and back, and that's my goal for this week. And then put it into place, because often what people then do is if they don't achieve it, they then say to themselves, oh, I've just failed, it's just a complete disaster, why ever bothered? So it's quite easy to slip into that. So getting people to make if-then plans. So if I don't manage to do this week, then next week I'll do this. So they've got a plan in place for if they don't manage to achieve their target behaviour that week. So I think that's really helpful for people. And I think the other thing is there's starting to be a number of apps for people and websites that people can visit, and there's a really good one called Stick. So it's STICKK, and it's been developed by behavioural economists, and it helps people. It's using behavioural science to develop the programs. And it helps people to kind of start up on new healthy behaviours, so stop smoking, eating healthy, being more active, and it helps them kind of get to a point where they maintain that. So that's a useful resource.
So at a national level, it sounds like you're basically saying, let's make it simple. Let's give
Make it
people really
simple,
key steps. Let's not
fun.
try and overwhelm people with big overarching statements that the nation's got to, half this by, like, just keep it realistic and piecemeal.
Yeah, keep it real for an individualized as well, so people can, it's personalized to them rather than, not everybody wants to do couch to 5K.
Yes, this is it, yeah.
So it's just about finding something that you like to do and that you find
In your way.
attractive activity. Yeah.
Yeah, I think from two angles really on this one. One is on bringing in primary care, and I think it's really at a national level. It needs to be how the funding is directed between public health and CCGs. Now,
So I'm gonna need you to do three things.
three
Explain
things
primary
there,
care,
yeah.
explain CCGs, and explain the public health.
So primary care, essentially primary care means things that are done for health outside of hospital. So that usually encompasses things like general practice, and it might be other things such as physiotherapy. And then the second one was about CCGs, wasn't it? So CCG is a clinical commissioning group, and they are responsible for deciding what services are funded by the NHS in any part of the country. So each part of the country has their own clinical commissioning group. But what I don't know, because it's not my area of knowledge, is how that funding is currently set up in comparison to public health. I think they're two separate bodies.
Yeah, public health is a separate body
in
to
terms of
CCGs,
funding,
yeah.
and that's where the disconnect is, because public health, if we get it right, impacts on what we're spending on in primary care, which is general practice. So that needs to come together. If we're trying to improve people's health in general practice by throwing more money into the NHS, but that money is being focused more on, say, medications and drugs, then that's not potentially a really good use of this in terms of enabling people to live healthier lives. And public health is trying to do that, but I think there needs to be a complete bridge of this gap between the two, because, for example, Man versus Fat and Beat Street, both of those I've never heard of, and I feel like GPs, we should be knowing about this, and we should be pushing this across to our patients. One of the success stories, which again isn't for everyone, is Couch to 5K. There's been a real drive from the Royal College of GPs to take on Couch to 5K, and for GPs to sort of build a community within their own general practices. And this has happened in Warwickshire, where I've noticed a few general practices on a Saturday will offer to go and do a go to the park run. So I'm getting confused between Couch to 5K and park run. So park run, for example, that one's been also endorsed. They've both been endorsed by the Royal College of GPs. And park run, there are some known GPs out there. Dr. Zoe Williams, one of them, she's on TV quite often, and she is an advocate for park runs. And so these GP practices, on Saturdays, they will say, we're going for a park run. Whoever's in our practice, come and join us and say hello at the start line. And then people do this together. So that's a social improvement as well as an exercise improvement. For me, the overriding thing for me on this is making it easy. So in a way that isn't seen as a negative, but basically making people do things insidiously without them even realizing that they're doing it. Whether that's walking to work, whether that's cycling because it's easier to do than taking a congested tube or taking a train or even driving. I think those kind of things needs to be in place. And it's education as well. If we want people to really do this, it needs to be part of the curriculum. It can't just be PHSE, which stands for Public Health Social Education. Is that right?
Yeah.
I'm not a teacher, but PHSE, right. I remember that at school as well when it was first just launched. But it needs to be more than that. If we want people to be healthier, then there needs to be sort of more solid subjects around that and why it's important for them. Like, for example, with my entrepreneur hat on, if we want people to understand what it is to run a business, then we need to give them the skills to do that. If we want to become an entrepreneurial nation, then we've got to give that to the schools. And same with health, we've got to provide that to schools, and we've got to put weight on it. So it's not just thrown at the end of a day or thrown in the middle of the day and optional.
Yeah. So actually, almost the conversation, it sounds like you're all saying at a national level, is not only make things easier, but actually how do we start to embed it in some of our infrastructure, whether it's education, whether it's communications? But then kind of coming from that communications angle, you've named 3 or 4 experiences between you that seem to have, either caught fire or caught lots of professionals' attention. So I know with this organization, Steps to Your Healthy Future, that they've been looking at a campaign around sugar, and it's called the One Less campaign, which is, maybe 1 less spoon of sugar. I don't know the full details, but even just that as a notion, how, again, this isn't me asking you as experts, just your inkling, your lived experience as professionals. How do you think certain campaigns catch fire professionally? Why do certain campaigns get endorsed by Royal College of GPs, and why might public health like a particular campaign over another? What are there any things that you've observed in your working experiences why certain ones are more popular than others? Or
You mean with the public?
yeah, with the public and
Yeah.
with professionals, because again, arguably, let's just say mental health first aid. I'm quite impressed with that because again, it's not the first type of first aid intervention, but that one has caught fire, and there's got to be a reason. And I do wonder whether it's influencing professionals makes it a little bit easier. Like, which comes first? The professionals like it, then the public love it, or do the public love it and then the professionals listen? I don't think it tends to be public first, but I could be wrong.
I think certainly with the public health campaigns, they're designed sort of centrally. So there's a public health insights team that design, the marketing team that designs the campaigns based on behavioural insights. So a lot of research goes into those campaigns. And then I'm guessing that what happens is that those campaigns then run, and depending on the reaction, so they're piloted often as well first, there's lots of iterations, and they're piloted. And then if people are responsive in the right way to them, because the people might respond but not always in the right way, then that's when they would kind of roll them out, and they become kind of part of I can think of an example. So for example, Stoptober. So I think that was probably just a one-off initially to see how that went, but it's worked really well. So it's getting people to quit smoking for the whole month. And now it's kind of a national yearly thing, and it's really kind of taken over from No Smoking Day. And the benefit of that is it's a whole month, so rather than just one day quitting. So that is and we know that when people stop for a month, they tend to then stay stopped.
And you using that example helps. I'm then thinking, well, how did Stoptober use the whole change of the environment? And then I can remember times where alternative patches and all of that then become more available. Then it was a case of let's support employers to make it easier for employees. So actually that's a really good point, where maybe actually to make certain campaigns work, you've also got to help the environment in which that intervention can occur. And I wonder, like, how do you access professionals and GPs such as yourself? How does a campaigner access you as a GP?
This is exactly what I think we should have more of, which is getting these campaigns to GPs as well. And I don't know what that communication cascade looks like, but I think it needs to be an internal communication, because as GPs, what we see about Stoptober is exactly what everyone else sees. We see it in the media, we see it on the adverts, and we see it in the press, but we don't get our own internal communications about it. So for example, what is portrayed to the public shouldn't necessarily be what we see about. The information should be slightly different. So we, for example, should know that in Stoptober, I know that the chance of a successful quit attempt during or after Stoptober is much higher. I don't know the exact figure, but if every GP knew that, because I've gone away and read that and worked that out. If every GP had an email saying Stoptober's coming up, your patients are twice as likely to quit smoking, and that went to the nurses who normally deal with the stop smoking cessation in the practice, or the pharmacists, then we might even be able to increase rates even higher, because they're ready for more appointments. They're ready to offer appointments. They might even text on the free text messaging services that you might have with your GP. They might even text them and say, it's Stoptober, come and stop smoke. We'll help you stop smoking. So I think communications internally could improve, because we get really good communications from a medicines management perspective. If there's a drug that's being recalled, or there's a potential side effect that's new on the market, or a new medicine, we get really good internal communications, and that does come from NHS England. So I think the same communication should come through from public health. What was the question that you asked earlier? It was about an example. No, how do things get picked up?
Yeah, how do certain campaigns sort of catch fire?
I think we're in the age of the influencers, and I think there may be two parts to it. One is that the government and public health, you can correct me, are picking up the people who they feel are influencers, and influencers independently are picking up certain things. So, for example, you've got to look at and you've got to give credit to certain media companies, including the BBC. So, an example is Dr. Zoe Williams. Not everyone knows who she is, but she's on one of the morning breakfast shows. ITV. Good morning.
This morning. Not
so
that I watch daytime.
So you do watch it. So now we know what you're doing in the morning. Is that why your day starts at midday?
It's with Fern and Phil, and they're my spiritual gurus.
But yeah, she's on there. So she's now an influencer, and I'm pretty sure she's on Instagram. But
she is on Instagram. Yeah.
So. And then the general public see her all the time. So it makes sense for a GP who's an ex-gladiator who's into fitness and nutrition to be the face of a campaign. So if she's endorsing, I think it's Couch to 5K or Parkrun, one of them, she's endorsing that, then people are going to see that and they're going to do that. And she has a place to talk about it on TV. And then you've got another doctor called Dr. Rangan Chatterjee, who did Doctor in the House on BBC, which was hugely powerful when it came out 2 or 3 years ago. And again, his message has been picked up independently, I would say, because of the support he's had around him with the medical community. That was more of a grassroots support. He's then written his 2 books that have come out, and they have had huge response from the public. They're bestsellers, not because people have endorsed them necessarily, it's because the information in them is excellent. In a way, they're both influencers. People are trusting these individuals, but it's making sure you trust the right person as well. But I would say that these 2 individuals are the right type of people that should be out there and should be continuing to say what they're doing and what's working.
Okay, that's really interesting. So who else would you say doctors listen to? So doctors listen to, their associations, and I'm guessing NHS.
The TV.
Really?
Yeah, and social media, but I'd put that in the bracket of anything visual, video based. People listen. It's really hard to filter information out there, and so that's why the new government organisation has been set up to try and deal with that as well. I can't remember the name of it, but I think it's just coming through now. And there's adverts on Spotify, for example, on make sure you don't just believe everything that you read on the internet, and I think they're from the government. So it is the video, but it's obviously being careful what you read, what you watch. So I'm sort of digressing on this, but one strategy to try and deal with that is by combating the negative videos, or the ones with the wrong information, with more and more good information. So you try and flood it out. The other way to do it is to directly address the information that's not true or not correct, and call them out on it. So I think there's a double strategy there. But I think people are picking up information from videos.
That's really interesting, isn't it? So, I mean, some of the takeaway for me is very much think about making things easy to access, break down really complex information, make things people-centered, like start with, the people first. Understand that actually creating visual context in order for people to really absorb, and then the rest is, as it sounds like, just time and patience, which is give people the environment in which to make the right decisions and wait and see what happens. Yeah, that's been really for me really insightful. I feel like I just got a PhD in 40 minutes just because it's that high quality knowledge, but in a way that it's really absorbable. Marianne, what are your thoughts?
Well, I'm actually thinking about the use of technology within the area, and what your thoughts are on that. I mean, when you've talked about the app, how do you see that being carried forward, and what kind of advice would you give to people who are looking to kind of influence and make waves in health, how they can use technology to possibly gain insights, or use data, or potentially make innovative campaigns that will help people?
In terms of healthy lifestyles, there's a lot of apps out there already. So the kind of, I suppose the concern I've got is that they're not all evidence-based apps. So some of them are better than others, but there's a lot of them purporting to kind of help you to do this, that, and the other. But the evidence that they actually work is a bit patchy, really. So I think when we've got a responsibility, in working in public health field, to make sure we let people know, and also to professionals, what is an evidence-based app. So we know that the techniques that it's recommending people do actually work for people.
And that's going back to people really checking sources, essentially, I think, isn't it?
Yeah.
Anyone can put an app out there and anyone can build something. The most shocking one for me that I'd heard about but never seen it is a patient came in on a weekend in East London and told me her blood pressure readings. And I said to her, how do you know, do you have a blood pressure machine at home? She goes, no, it's an app on my phone. So I said, I know about this app, let me see it. And she literally just put her fingerprint on the app and it told her blood pressure. And I said, you can't measure your blood pressure like that. She goes, look, it's a number, it's a reading, look, it's got great reviews, and it's got thousands of reviews saying it's great and stuff. And I had to show her, look, your blood pressure's 20 points out on my blood pressure machine compared to that one. You need to bin this stuff. This is not safe. And so when people don't have the knowledge, you can't blame them for picking up certain things and then saying this is safe. There is a new organization out there called Orca, and they have launched. They have been around now for about 3 or 4 years, and they independently verify health-based apps. So there are thousands and thousands of apps out there. So how do you know which one? They obviously can't verify all of them, but they provide a service for that. And I think they've just been endorsed by the NHS as well. But I think it's with NHS Digital. So that if you look out for their logos, you can find out they actually rate apps. So you can see how good the evidence is, not just a black and white. It's either good or bad. It's how good is it as well. Yeah.
Yeah. Okay, that's good. Good advice.
So technology is moving so fast that the regulation can't keep up with it.
Yeah.
And so this is now, I think this year and the end of last year is where the regulatory bodies, whether it's from the government or whether it's from the NHS or independent, they're all starting to come through now. I mean, I've had an online healthcare company which I've just recently closed down. And the thing that I've learned from it is it's just another medium. At the moment, if we're looking at it from an information perspective, technology is another medium, but we shouldn't look to it as the answer either. Like what the conversation today actually hasn't really been about technology, because initially we thought technology was a nirvana for everything, but it isn't, because technology isn't human. Essentially, the things that we've got to put in place are human. So whether that's behaviors, we're talking about things that people do, talking about walking and cycling and things like that you can't, just by downloading an app, you're not going to become healthier. It's about what you do with it as well. And I think that comes down to how does that motivate people, an app as well. So yeah, I'm not, like you said, like what's the evidence base behind, and how good is an app going to be? I don't know I can't think of an app yet, apart from ones that enable healthcare.
I mean, the Beach Street. Was that like a check-in system kind of thing? Yeah. So I mean, in that degree,
that brings out the human element, doesn't it?
Exactly,
it brings out that was another thing that I would say.
Both, isn't it?
There's gamification as well, and another big area trying to get gamification. Whether that's, and it's a big growth area for businesses, which has grown from advertising and marketing, and that's coming now into sort of public health, I guess, isn't it?
Well, that's what Beat the Street essentially is. It's gamification. Yeah.
So possibly if someone from a health organisation wanted to go down that road, that's the kind of area that they'd look into, rather than the apps. They'd look at gamification, because it's kind of social prescribing, and it helps people. I mean, to that social prescribing, I mean, you'll know the definition more than you can explain it more than I can, but it's getting people out and about.
So social prescribing, really, it depends. I suppose in its traditional sense, it was GPs prescribing kind of activities that were often kind of supported through another agency. So, for example, a health trainer type agency, or just signposting people to particular activities, because there's a recognition that a lot of the appointment time that you'll spend as a GP spent seeing people who don't actually have a physical condition, or they might have a condition, but there's not much more you can actually do at that particular time. But they're presenting really with loneliness, and the social. And there's a growing body of evidence around social connectivity and the impact it has on people's, or a range of conditions, people's mental and physical health.
There's a new program on social and lifestyle prescribing with the Royal College of GPs, and now they've trained over 600 GPs in this. I'm due to sign up to the course as well. I'm really looking forward to it, because if we can give more than just pills, but do it in a way that is still scientific and evidence-based,
but constructive
and something that we can monitor and follow up, because it's no good just saying to someone, right, we'll see you in 6 months' time, just eat healthier. That just won't change anything. But if we give them specific constructs in a way that a prescription might be done, then they might get ownership of something that they're doing daily, things like that. I think you're more likely to enable change, especially when the health professional saying it, and the health professional is going to hold you accountable in a few weeks' time or a few months' time.
And that lends itself to people there are people that do want to be told what to do. And they feel comfort in a professional telling them what to do. It's now just making sure that we equip that professional with a range of tools rather than things that might be intrusive and invasive. Because I believe in the Black Country area, and I want to say it's Blackheath, but I do know of a place where I think back in 2017, they started doing social prescribing almost as a pilot. I don't know where that project is now, but that's really, that's such a good point, that actually it's about people, never forgetting it's about people, and then, doing the right things in the right order.
For any policymakers out there, let's bring public health and primary care together. Let's get that communication better, because I think that really makes a difference, especially within the medical community. The doctors are asking for it. Patients really want it. This alternative way to manage things. There is no one out there who wants to take 10 medicines a day. And there are so many people out there who, given an alternative, would take it. So I think together we can continue to drive that message.
Yeah,
thank
brilliant.
you so much.
Yeah, thank you. Very thorough. I feel like now that I can go home and put together a 3-month plan of what I'm going to do, and then if that one doesn't work, the next week it's all good. So thanks ever so much for your time. And that is the end of the Leading Communities podcast this week. Have you got any social media platforms that you want to let people know about that they can connect with you on at all?
I am currently active on Instagram, and I don't mind if people follow me there. It's at Dr. Sodha, so that's the @ DRSODHA, and that's probably my most active platform.
I'm on Twitter. I think I'm Alison Trout too on Twitter. Yeah.
1 T, TR.
1 T, yeah. 1 L
Okay.
in Alison, yeah.
All right. Brilliant.
Okay, brilliant. Well, thanks ever so much, guys.
Thank
you.
you. Thanks.
Thank you for listening. To keep up to date with Leading Communities podcast releases and updates, follow us at A4UCIC, at Ideal Directions, and at That's All Media.